Fuster.
Yes, we have a very special guest that honored us to come here. Dr. Fuster has been my mentor, my advisor, father figure. He's the only one who screams at me, and I'm still happy when he does. And a few words for some of you and thousands of people or tens of thousands of people who are will be watching through Zoom recording that it will be on YouTube and everywhere. Dr. Fuster does not need introduction, definitely not for me, but I have a few observations that I would like to take the opportunity to say, American Heart Association past president, Dr. Fuster, and American College of Cardiology, leading cardiologists, for us who've been in cardiology for years and decades, names like Paul Dudley White or Lewis Connor, these names have been around for, a lot of these lectures and so on. I would like to argue that Dr. Fuster outweighs the weight that he brought to cardiology, all other names in cardiology. And here's why. It's not because he is a basic scientist who mastered clinical cardiology and who mastered epidemiology. But to my knowledge, he's the only cardiologist who crossed the borders. So imagine you be a great basic scientist because he's developed a big chunk of our understanding of thrombosis. Vascular thrombosis was from his early PhD work. He has a PhD after his MD. And then he has developed a lot of these knowledge of clinical cardiology. He led the textbook that most fellows read. But then he didn't stop there. He went back to the social aspect of cardiology. So some of you may not know, Dr. Fuster has a figurehead in Sesame Street. And that's called Dr. Rooster. And Dr. Rooster teaches children about early prevention of heart disease and living healthy life. I do not know of any cardiologist who has done that. And then he went beyond and went across the border in different countries, especially South American and poor countries, tried to influence whatever power he had in their policymakers, which now I'm going to conclude what he's doing with us, with this group. He literally got on a train and went to Medicare with me because he believed and saw the value of coronary calcium score in early detection. He didn't have to do that. He was a president of American Heart Association, and chief editor, the longest chief editor of journal. But he is the figure that brought science, public health, and technology, because he ran a bunch of these imaging that we have seen pretty images from him. So it's really an honor to have you, Dr. Fuster, and we hope to take on that legacy that you started and turn it to preventing a lot of preventable deaths through this conference. Thank you.
Well, thank you, Mort. I hope I don't disappoint you after this presentation. Well, thank you very much for having the opportunity to be here today. And, I was in San Diego yesterday, and this was the presentation that I made, new concepts in cardiovascular prevention, challenges in the two extremes of life, the challenges in the elderly and the challenges in childhood. These two extremes of life actually were addressed within the context of what is in the square in the middle of the slide. And that is, we have a paradox here. It's a tremendous evolution in technology, but there is a tremendous deficiency in education. And we are all excited about technology. I am excited, you are excited, but I will tell you there is also a problem here. And mortality in cardiovascular disease is increasing. So something is wrong that doesn't go along with the improvement in technology. And this is education, as I will show you today. So let me see if I can, let me talk about the evolving role of technology. I had a crisis about maybe 10 years ago I was working in the bottom of the slide, understanding this problem, arterial disease, until I realized that we knew less about health than disease. So I decided to do the following things, to move up and then try to use the most modern technologies in understanding health. It's very simple. This is imaging. This is a cell that defends us from foreign bodies. It's a macrophage, monocyte from the bone marrow. New therapies, and this is interesting. There's a lot of future here. For example, we believe in the RNA type of neutralization in the liver with many things that happen in disease. And I will talk in a moment, in artificial intelligence. So what we did is we got all of these and we move on into 3 different ages. Birth to age 20, age 20 to 60, and age 60 to 100. Yesterday, I talked about this. Today, I talk about this. And that is to focus between age 20 and age 60. So to do that, let me say that I will say a few words later about the 2 extremes of life. But let me start by talking age 20 to 60. This is a key study that we're involved, and I developed this in 2010. It's the so-called the PESA study. We're dealing here with 4,200 individuals, 1,500 are women, that actually the age is between age 40 and 54. And what we are doing in these people, we are following for every 3 years, for 20 years, with very sophisticated technology. Basically, this is what we are doing. Technologies we are using, 3D ultrasound for the arterial, to look at the arteries, computed tomography to look at calcification, and positron emission tomography and MRI, basically focus on the arterial system. I have to say this from the very beginning. And then what we do, we look at the body below the neck, and then we look at the brain with all these technologies. And then what we look at is the part of the slide that is important. Deep phenotyping, lifestyle, diet, risk factors, artificial intelligence, we have more than 4,000 parameters. And here in the bottom, everything you might think about multiomics, genomics, metabolomics, etc. What I'm going to present to you some information, and most of the information actually has been obtained in the last 3 years, and some is coming up now. Let me start 4 aspects. I will first talk about the PESA study, age 40 to 55 years. This is for 4,200 patients, apparently normal individuals, that we scan the carotid arteries, the aorta and the iliofemoral arteries with 3D ultrasound that we now have completely automatized. And we just published that, and that is, it is a high incidence of subclinical disease at age 40 already. But the disease, actually, we have already the data start at age 30. And actually in the iliofemoral region in 75% of people. So we forget about the legs, but that's where the disease begins subclinically. And the thing is that doesn't cause any clinical problems because the arteries are very large. The problems come with the small arteries, the coronaries, and so forth. That's the story. Then we have, every 3 years, we follow these people. The progression rate of the subclinical disease is 33% at 6 years. What is most fascinating is this. Actually, if you have an LDL cholesterol that is high, let's say 160 at age 70, has much less impact on the reactivity of the arteries than the same LDL cholesterol at age 40. So what we have learned is that the body is much more reactive at young age than in the elderly. What that means is better we start looking at something that subclinically starts at age 30 and at the same time has much more impact than what happens at age 50. And this really moves us into the younger age population. Well, about guidelines, they're absolutely primitive. I have to confess this to you, and I will give you some examples. If you look at guidelines today, a normal LDL cholesterol, for somebody who never had cardiovascular disease, they say between 85, 90 to 110 is okay. Well, in color is subclinical disease. So this is normal. In other words, a normal LDL cholesterol in somebody who's completely up, doesn't have any cardiovascular disease should be less than 70 or 60. We have the data. This is subclinical disease. But let me tell you about diabetes, which is interesting. This is going to be published, actually, I think, in the next couple of weeks. This is fascinating. This is pre-diabetes. You know, hemoglobin A1C, you know the levels. And we say pre-diabetes is an alarm system for diabetes. It's not an alarm system, it's big trouble. This is the color. This is subclinical disease. But look actually before pre-diabetes, it's insulin resistance. Before pre-diabetes, you have a lot of subclinical disease. So what I'm really talking about, all the guidelines, they go into age 50, 60, Framingham. Let's see what is the rate. Excuse me, my friends, all start at age 30, and the trouble is at that age. So if we don't pay attention there, I don't think we're moving along. And this is actually what I'm learning by studying health. That is, we know much less than studying disease. Well, this is an example, and this is point number one. I said I have four points to make. Point number two, if this subclinical disease progresses, as I mentioned, the question is, this means cardiovascular events in the future. That's an important question. So we work on the cardiac study, a study of 30 years ago. I'm sorry for that. And basically, what we did is, what is the impact of a risk factor between age 20 and 40? I'm now earlier and earlier. This is LDL cholesterol, triglycerides, blood pressure, etc. But what we do is we measure this area, which is what happened in 20 years of exposure to a risk factor. And this is like cigarette smoking. The data is here. Basically, the red line means the highest area for LDL cholesterol. This is the lowest. This is for blood pressure, etc. No question that disease at young age, subclinically detected, is telling you a trouble in later age. This is the story. And more is coming up soon, but I presented to you the basic concepts. Well, this led to a study that we started 3 days ago. This is in the whole Mount Sinai system, which is how we pull all of this together. A study, that's a prospective study. It's called PRECAT. The PRECAT study entails 2,000 young people, well, between 30 and 49. This is abnormal, with an LDL cholesterol more than 70. And these people are randomized into 2 groups. One group is a standard care. These are young people. The other group is inclisiran, twice a year. Why? Young people don't take statins. We have already pilot data that I don't want to bother you with. Young people don't want to take drugs, so subcutaneous injection twice a year. And what we are going to measure is in young people, progression of disease. But somebody skeptical may say, measuring progression of disease means nothing. What about cardiovascular events? Before in the cardiac, talk about risk factors, not imaging, prognosticating. Well, this leads actually to the third point. This is going to be published actually next week. The bioimaging side, this is how I started MRI in the arteries, but then I moved into 3D ultrasound in the large arteries, and this is 15 years ago. And the data is coming out. Basically, this is a study, 55 to 80 years of age. And we follow these people for 13 years. And the question is, what happens at point 0? Can the degree of disease, this is imaging, actually use ultrasound in coronary calcification? What is the prediction of ultrasound when the disease, the burden of disease already at this point is significant, very significant? In other words, what you can predict is something that is silent early, you can predict later. There's a lot of people here on the calcification story. It will be published next week. You will see. It's a little bit better than calcification. Not extremely better, but it's better than 3D ultrasound. This was all done blindly, by the way. And this is about mortality. But here's the question. And the question is, we found that risk factors indicate progression, the PESA study. Risk factors lead to cardiovascular events, the CARDIA study. But this progression of disease leads to cardiovascular events, and this is the key data. The key data comes from the bioimage study. And it is in these people that the disease progressed because we had a group that we follow systematically. The number of events is very significant, pointing out that the three statements are actually correct. Why this is important? Because in the pre-CAT study, we have young people. They don't reach cardiovascular events. But according to the statisticians, it is correct as a secondary endpoint to say, wherever you see progression, this is what is going to happen with cardiovascular events later on. So it's a secondary endpoint. And this is the pre-CAT study and the bioimage study now together. Well, there is one point that you might be less interested, but I hope I can motivate you to be more interested, and that is the bone marrow. The bone marrow is critical because the bone marrow sends to the blood the cells that take care of foreign bodies. You can call whatever it is, COVID-19, or you can call cholesterol in an artery. The bone marrow actually reacts. And the question of the bone marrow is to defend you, to get all this foreign material out. Well, so I go back to the PESA study. 900 individuals had PET and MRI. And the PET, interestingly, it tells us what happens in the bone marrow is activated. And this correlated very well with this conglomerate in the artery, which is actually the interaction between monocytes and lipid material. This is all published in much more detail. But here's the question. And to us, this is fascinating. And the question is this. We now have the natural history in our individuals. We follow every 3 years. And this is actually what in autopsy said fatty streaks. And the fatty streaks were a cholesterol deposition with some monocyte interaction. This is healing, magnetic resonance imaging, looking at the fibrotic phenomena. This leads to this in the cases that this doesn't progress. That is, the risk factor profile is being addressed, and the cholesterol is not significantly high enough for these cells. They can do the job, I mean the monocytes, and then this ends up with a fibrosis. We call this compensated. Now I'm going to give you a sense of what I think acute coronary syndrome is, myocardial infarction, and actually unstable angina. What I think is happening, and we have the data already, I believe, is that when this is very significant, the cholesterol deposition, the bone marrow cells say, I cannot do my job, and they kill themselves. This is called apoptosis, as you know. It's a biological phenomena that is not passive. The problem with apoptosis, cytokines are being released at the same time that the cell that is supposed to defend you is in trouble. This happened with COVID. You know, COVID, patients going to the hospital, some need mechanical support. There's a lot of thrombosis all over the place. And what's happening is the macrophages cannot do the job. The density of the virus is too significant. They kill themselves, they release cytokines, and this is the COVID that goes to the emergent, to the mechanical support. The same happens here. And we think that when this is very significant, the monocytes give up, they release two very important cytokines, tissue factor that causes the clot, and metalloproteinases that rupture the plaque. So what we are really telling you that, to me, an acute coronary syndrome is a failure of a defense mechanism. In the bottom line, there is too much substrate, and the cells that are supposed to defend you, they do the opposite. They kill the artery at that particular level. But there is something else. We see so many people without obvious risk factors that have heart attacks. And the question is, what is going on? And I want to talk to you for a moment about something very exciting, which is CHIP. Many of you learn about CHIP. CHIP, basically, the bone marrow cells that are supposed to defend us have a mutation, and they fail, genetically speaking. Now, this has been a concept for a few years, but the question is, what are the details of this? Well, we went back to PESA, And we began to study this, and factually, this week, this is published in Nature Medicine. And it's actually fascinating because the question is the following. The question is 20 to 35% of adults have mutations of the cells that are supposed to defend us. And this is a problem. Without going into much detail, these are actually the findings. This precedes subclinical disease. We have the whole data. And that is all it starts at the bone marrow. These cells fail because they cannot defend you. You might not have any risk factor, but the reality is this is proactive, very proactive in the arterial system. The cells are completely distorted. And it's interesting because you would say, if the cells are not acting, the defense mechanism doesn't exist. The problem is, this is in part true, but in part, CHIP provokes significant inflammation by itself. And there is something else. Actually, as you can see, I'm very excited because this is all new, and it's all with new technology. We are studying health here. That's what we are studying. Well, this is about colchicine. You heard about this drug, of course, with gout and coronary disease, but I have more to say. We have an animal model that has actually has this problem of CHIP. And the UK Biobank, they look at CHIP. And what we both have found, that colchicine inhibits all the individuals who have CHIP. In other words, all this promotion for atherosclerosis and inflammation, colchicine gets that, particularly in those who have bone marrow mutation. I think this is fascinating, at least to us, and we are now beginning to learn it's not all risk factors, it's something else, but there's one issue you will never forget. Imaging, it tells you the highest risk individual. And that is you have to start there and then move on into the rest, because means the disease is already starting. Well, with this in mind, I have to say that I cannot stop here, but I have to go to the brain. And it's very fascinating. Alzheimer, about 100 years ago, pathologists said, my disease is a disease of the arteries. All the research has been on the neuron. And the question is why? And I can tell you why. Because if you have cognitive dysfunction or Alzheimer's, the first thing you think are the cells of the brain. Therefore, let's attack the cells. The tau deposition, the amyloid beta, and all research really moving in that direction. Nobody look at the arterial system with new technology or the microcirculation. And this is what I want to present to you now. This is absolutely new, but I think it's exciting in this forum, the importance of imaging to know what is going on, not only in the body, but also in the brain. So this is now talking about age 60 to 100. The challenge is the brain. I think you are in agreement with cognitive dysfunction, Alzheimer's disease. What we are talking about, let's now go to the same technology that we have been using for the other PESA study in age 20 to 60 and see what happens. Well, you know, I have to confess, I'm presenting to you data that at least I may have been the cheerleader, but there are young people involved. I want to say to you, this is why you will see a number of pictures of young people, because sometimes we don't realize we come here in a podium and this guy is presenting fantastic work. I'm sorry to tell you, this is work of young people on a team effort that work with us. I want to make this very clear. And this lady, Cortez, Marta Cortez, is the leader. But I will tell you 50% of my research today is in the brain, because I think it's something we have to learn much more about it. And I frankly think we have the tools. This is how we started. In fact, this is a mistake. This is 2015 to 2021, a transatlantic study between Mount Sinai in New York and actually the National Center of Cardiovascular Investigation in Madrid that I'm working there. And here's the issue. We learn from the pathologists. This is very important. The hypertension, diabetes, and hyperlipidemia may affect the microvascular of the brain. That's the key issue to start with. And you know what? It's not atherosclerotic disease. It's intimal thickening. And the artery or the microvascular gets narrow and narrow. So we said, let's do flow with MRI of the brain of people who have diabetes, hypercholesterolemia, and hypertension. Let's see what happens. We did it, and we found decreased flow. This is all published. Then we did uptake of glucose by PET in the brain. And when there is low flow, risk factors decrease in the uptake. And then the question is, this affects cognitive function. We are working on this. I don't want to go so far. But this is point number one. But what about when you follow these people? What happened? This was published in The Lancet about 5 weeks ago. And this is the uptake of glucose in the brain at baseline. And this is 6 years later on people who have the risk factors that I mentioned, 370 people. So what I'm trying to start telling you is better we pay attention to the brain, because these are risk factors that they start at age 30. And the heart reacts at earlier age, but the brain at later age. But you know what? It all comes from the same type of pattern. So what I'm telling you, that prevention is critical. I think this is obvious. What we are saying is we are too late in the game. This is really what I'm saying to you. And let me go to calcification for a moment. It's interesting. I believe on coronary calcification score. I would be crazy not to believe on the tremendous impact. But I will tell you, in younger people that we have used it, there's a lot of, I would say, false negatives. You know why? The plaque is too soft. And there is no calcification yet in a 30, 40-year-old. And then you have subclinical disease with 3D. The same progression of disease. To use calcification to see if the disease progress, maybe healing is progressing. 3D ultrasound gives you the answer. I'm just telling, I'm very much CT calcification guy, but I have to tell you 3D gives more information in the general body, particularly in young people. That's what I'm really talking about. Well, this is the brain, and here comes the issue. The uptake is decreased, and then, like in heart, we begin to use troponins telling you the muscle is in trouble. Now, this is happening in the brain, and it's fascinating. This is called neurofilament light chain. For the first time in the last year, we're able to measure a circulating blood biomarker that is telling you the brain is beginning to be under stress. And that's the one. And this is very fascinating to us. Well, there is a problem with what I presented to you. Nothing is clear. Not the same individuals, the 300 people, not the same individuals had all the technologies done. So one has flow, the other has PET, all the risk factors are there, and then you say, I am right on the hypothesis, but the only way to prove the hypothesis, everybody should have all the technologies. And this is the project number 3 that we began in 2022. And it's a project with 1,000 people. We are doing all the technologies. This is actually imaging in the brain, and this is biomarkers in the blood. And I will say to you, the project is very complex, but it's very exciting. With MRI, we measure everything that you know, whether it's flow, structure, everything. With PET, everything that you know. And this is done in all the individuals every 3 years. And this is 1,000 individuals. To really follow with imaging, I'm so into imaging. This is why I'm excited to be here today. They are following with imaging what really goes on, because we are learning a lot. So a final point that I would like to make is, well, this is obviously, we look at the arterial system too. A final point I want to make, and is we have an animal model of Alzheimer's. In this animal model develops Alzheimer's disease, but with what we see, I'm sorry for this, what we see something very striking. The microvascular, the so-called amyloid beta is procoagulant. And we see small clots in these animal models. And as we publish in the British Journal of Pharmacology, we can prevent these with drugs that we give to humans for atrial fibrillation. Very interesting. So here's the question. Number one, Alzheimer said, my disease is arterial. I don't know if he was seeing clots or he was seeing the risk factors affecting the microvascular, whatever it is, but he saw something, but never wrote what it was. And that's the story. So something is going on here, either with risk factors or with blood clots, etc. Why I say something goes on? Because the data I presented to you in the uptake of glucose is in the same areas that is affected with Alzheimer's disease. So actually our concept today is Alzheimer's disease is very complex. The amyloid beta, the tau deposition, but the arterial disease, we believe, it makes the disease, Alzheimer's disease, to progress. That's the real issue that we are working on at the present time. Well, this is actually all what I wanted to tell you about technology. I can stop here because this is I only wanted, if I could, to tell you about education, but maybe we'll leave it here because it's a little late. And what I was,
We would like to take some questions.
Sure.
That people had also. So I want to start by saying you're, as I said at the beginning, you're the only one that I know that you took the clinical and all the basic science and you took it to the population. Now, if we implement everything we know, if we stop discovery today, no more discovery, if we just implement what we know about cardiovascular disease, what do you think will happen? I'm just saying that I think half of the cardiovascular disease that we have today could be prevented if we just implement.
No, I
So
think-
if you could comment on
tend to
on
agree,
the implement part.
I tend to agree with you, but the problem is how the implementation is going to come into fruition. And that's what the second part of my presentation is. In other words, we have a lot of information today that is meaningful for the population at any level you want to look at. But the question is, how can you make this to happen? Everybody, when you go to the public, and sometimes a journalist tell me something that really is a formula for health. And I say, it's your head. Everybody knows hypertension is bad, smoking is bad, and so forth. But the question is, you have to decide if you take care of yourself. And this is a matter, I would say, of education. And it's very, very complicated. In other words, what we see is we see lots of people with risk factors, and you tell what to do. It lasts 3 days, and then they are back to the same thing, and it just is not working. So I think that we have a great problem here is how you implement what we have today. I agree with you, what we have today is a lot. And if we use it, we'll make a tremendous difference. The problem is, and it's very, very striking, the problem is that despite of every technology evolving, let me present only one slide,
Yes, please.
because it gives the answer.
Yes.
Mortality in the United States is increasing.
Mm-hmm.
But not only in 2015, I could show you the data of 2024. And in the United States, mortality is increasing despite everything you guys talked before, and I am talking here. And in middle and low income countries, it's even worse. So there's a problem, my friend.
Yeah.
And that is we are all enjoying all of this stuff and all the technologies. It's fantastic. Artificial intelligence will tell you the truth. You know, look at this.
This is going wrong way.
If something is happening, and I was not going to talk today, but I will tell you what is happening. And what is happening, we did this with NIH and the Institute of Health of Seattle, 1990, 2000. You know the green is obesity. And obesity means diabetes and means hypertension. This is actually what happened. So I'm sorry, I don't want to go any further. So, but I just wanted to give you this story. That is, this is all so exciting. We have tools today, but we cannot use them.
Because it's not implemented, and you said there is a public education aspect,
Well, you know,
and there's a
believe
policy.
the next step is we are in children, you know, that's he said, Muppet at Sesame, because I think children are the only people who capture what we say. And if you start at young age, this comes out later in life. So we are dealing with 50,000 children around the world today, which is in education and health. That's what we are doing. Because otherwise, we'll continue to develop technology, but the whole thing is falling apart. And that's the reality, whether we like it or we don't.
And what about the policymakers? You know, you've been involved with American Heart Association, other
Look,
organization,
can-
and then
can-
you've been to
can I tell you
Medicare
something?
hearings.
I'm very skeptical. What I learned is the following, from the bottom up. You have to start from ourselves, from the families, from the people in the bottom. Education, education, education. The people on the top, they don't have time. They last 4 years and they go. And they have other things to solve. So what I'm telling you is I have a lot of, I don't want to get into this. I have a lot of experience with big organizations. And you know, in a word, I would say I am skeptical. There's a lot of good doing in that, but there is no impact. And that is, we have to change all of this. And going from the top down, there's only one issue, I believe, on the top. You know what it is? Is to develop a book in primary school system that says health. and make it obligatory. That's I am working with the higher ups. And that is nothing in primary school that really goes into health, into anything that we talk about health. Forget it, doesn't exist in children. And this slide, you know what it shows? Obesity in the adults, 75% comes from childhood. This is what the slide is. So if we don't do something at younger age, we have to continue to develop technologies. I'm not against it, and I'm in the middle of this, but I think we have to be cognitive that something is wrong here.
Technology should continue, but implementation, you're showing going bottom up. Do you mean empowering patient also and informing consumers to take actions on their own healthcare?
Well, I don't want to go into details, but we are going to the school systems in high income places, in low income. We are in the Bronx here, which is the poorest place in New York. And we are dealing with 50,000 children. All are randomized studies, which we implement health, and I don't have to go into the details, versus controls. And we are learning a lot about that. Once this gets into the public, I think it will have impact. And I believe that, I believe we have to start from the bottom up. I want to actually emphasize this aspect. We have a project in the families, for example, on health that is fascinating, the importance of the environment. If you go to parents, children, and grandchildren, the impact is incredible if you get into health. So we have a lot of things to say, but what I try to emphasize here is that as technology is advancing, education is not really going in parallel. That's all what I'm saying.
But that, of course, has a long-term impact. What are we going to do with that thing that is going up, like in the next 5, 10 years? What would be the lowest hanging fruit to, change the curve?
No, this is why I go to the primary school. Actually, our children, the 50,000, is between age 3 and age 5. And then we follow at age 10 until age 20. I don't want to prolong this. I only want to say that we are learning a lot. I am very excited to what is going on in the field of imaging particularly, but on the other hand, I just try to make us all conscious of the issue of education. Thank you very much.
Any questions, David?
More of a comment. In 2010, Claudia and I came to Mount Sinai and we brought our whole lung cancer screening program. And we've been doing these I-ELCAP conferences on lung cancer screening. And we had the pleasure of having Dr. Fuster speak in 2010. I don't know if you remember this, but you gave a talk, and here we're talking about lung cancer screening. We wanted to include something on cardiac. And Dr. Fuster started talking about the importance of education in children, and that this is where the action really needed to be. And I was listening to this conference and thinking, what is this guy talking about? Well, it's now 14 years later, and I am totally convinced that it was way ahead of the time. So it teaches me something also. We need to have him at more of our conferences. So thank you very much. This is a wonderful talk.